Welcome to AETCM, the emergency medicine channel. Today we'll be discussing a case of a young adult who presented to our ER with complaints of right-sided chest pain with breathing difficulty. Can we begin, sir?
Okay.
A 35-year-old male with no previously known any comorbidity, non-alcoholic, non-smoker, presented to our ER with history of 1 day history of fever. Along with that, patient had right-sided chest pain, which was the chief complaint. Along with that, associated mild dyspnea. So in our initial 10-second assessment, patient was conscious oriented, obeying to our commands. Primary survey wise, airway appeared patent, no hoarseness of voice noted, no increased secretions, and no anatomical deformity also was noted. Breathing wise, patient had respiratory rate of 24 cycles per minute, maintaining saturation of 88-87% on room air, with air entry being bilaterally equal on the upper lobes, but on the lower zones he had decreased.
Zone is not correct. Zone is in X-ray only.
Okay, upper
You can tell.
lung field.
You can tell the anatomical area.
Okay.
Supraclavicular, mammary, supraaxillary, infraaxillary, like that.
So in the infraclavicular aspects, patient air entry was normal, but in the inframammary and the interscapular area, patient had decreased air entry with minimal crepitations were
Clinically,
heard.
there is no inframammary area. Only mammary areas there.
Okay, mammary areas.
No, these are all basic MBBS. That's why I'm telling. We should not make mistake.
Okay.
It's mammary area. And if you want to tell below that, you can tell the exact interspace. 7th intercostal space, 8th intercostal, like that you can.
Okay. So the mammary area, he had decreased air entry a bit, and with crepitations that were heard.
Both sides or one side?
Both sides,
Both sides,
bilaterally,
okay.
but majorly on the right side, mild on the left side.
Okay.
Comparatively, but bilateral present predominantly on the right side.
Yeah, air entry is better than the right side. Left side.
Left side air entry is better.
Better, okay.
But it wasn't very profound, but
Okay.
crepitations and all were more profound on the right side rather than left in comparison.
Good.
So this was the respiratory finding. Circulation wise, he had a normal heart rate of about 74 beats per minute with a blood pressure of 128/70. All peripheral pulses were palpable and rhythm was regular in nature. Disability wise, he had a full GCS score of E4, V5, M6 and pupils were 2.5 millimeters, bilaterally symmetrical and equally reactive to light. Exposure wise, he had a normal body temperature of 98.6 degree Fahrenheit with blood sugar levels of 156 milligram per deciliter. As our adjunct, we took an ABG just to see if the patient has, because patient had an obvious desaturation of about 87-88% on room air. To rule out hypoxemia, we took an ABG. ABG did not show any acid-base derangement as such, and his PO2 levels were 60.4, so slightly hypoxic, and but no.
PO2 is 60. It is not slightly.
Okay.
It's a major,
Evidently,
evident. Major. It is very evident that he is hypoxemic.
So what
Then
is PaCO2 level?
PaCO2 was 50.1.
That is increased.
Increased.
So you should tell always both. So respiration is assessed not only with the oxygen level, with the CO2 level also.
Okay, sir.
Any respiratory depression manifestation is only PaCO2 or EtCO2 increase. Okay.
Okay, sir. And had a pH of 7.36 with a bicarbonate of 28.2. Lactate was normal 1.5 and
pH is how much?
7.36.
So what is primary survey?
So in our primary survey, so far what we have gathered is the patient is has dyspnea with low
No,
saturation.
what is primary survey?
Wherein we check the patient's
Assessment of any life-threatening situations in airway, breathing and circulation, and immediately correct A, then go for B, then go for C.
Okay, sir.
So now the saturation is low. Did you do anything to
Yes,
correct
sir, we
the...
put the patient on a nasal prong and at 2 to 3 liter of oxygen, he was maintaining 98% saturation.
and position?
Position, he was sitting upright with the
That
support
is also
of the
more
cushion.
important. Okay, comfortable position. When the breathing difficulty, head a proper position is better. Okay. So these are, first you finish airway, then go for breathing like that.
Okay, sir. There was no issues with the circulation, disability and exposure aspects. Only the main thing that we saw was the patient had was hypoxemic, which was corrected by putting the patient on nasal prongs, and at low concentration of oxygen itself, he was maintaining 98%
How
on
many
this
liters
one.
per
2
minute?
liters, sir.
2
2 to 3
liters.
liters
Okay,
of
good.
oxygen.
Good.
So this was our primary survey at Jenks, and an ECG was taken, which had sinus rhythm.
The
No,
ABG pH anything you did not mention
the
anything.
pH is 7.36.
7.36.
36.
Okay.
So ECG patient had a sinus rhythm. No acute STT changes were noted. Patient was complaining of right-sided chest pain, possibly a pleuritic chest pain, but we had to rule out an
Heart rate,
ACS.
how much?
Heart rate 74 beats per minute.
70. Okay.
So right-sided chest pain, atypical finding, but ECG did not show any signs of acute coronary syndrome, but possibly a pleuritic chest pain with a background of respiratory symptoms that the patient presented with. So,
Anything you want to add on the pain part to substantiate it is respiratory origin?
okay, so pleuritic chest pain has a classical variation basically when the patient inspires and there is more irritation in the pleural
Deep
ribbing, so
inspiration.
patient
Okay, coughing.
complains of pain.
Or sustaining that time, the pain will be more.
Yes,
Breath holding may be reducing the pain. Okay.
So the symptoms were more in sync with the respiratory component rather than the cardiac involvement.
Okay.
So this was our primary and a survey along with the adjunct. Moving on to the sample history, our secondary survey. Patient had a recent history of fall.
At this stage, you auscultated. Is there any rub, pleural rub, or any rub
Patient
did you
had
hear?
basically in the mammary areas he had reduced air entry, it wasn't very profound, sir, and crepitations were there. We couldn't really differentiate whether with the whole the classical finding of crepitations, pleural rub, I could not appreciate.
How do you differentiate pleural rub from pericardial rub?
Bend,
Ask the patient to hold the breath.
hold breath,
So the pleural rub means it will disappear.
disappear. Okay.
See, pericardial rub will be continuous with the heartbeat. Okay, good.
So in our sample history, we have a history wherein a patient had a recent history of dengue fever. On 8th of October, he was diagnosed to have dengue fever when he presented at that time with fever and myalgia. He was hospitalized at a local clinic, local hospital, and was discharged on 14th. Thrombocytopenia was corrected, and when the patient went in, the day of discharge, he was good.
How it was corrected? That thrombocytopenia, you told it is corrected. How? It was auto-corrected or
No, sir, self-limiting. Self-limiting, no transfusion history as such. So,
if there is a history of transfusion, what else you suspect?
trially,
Transfusion-related lung injury, we have to suspect. Because FFP, platelet, all these things are more prone for transfusion-related lung injury.
So on 14th, the patient got discharged. 15th, he developed another episode of fever spike, which is why he got readmitted. And at that point in time, he also developed respiratory symptoms, including right-sided chest pain. And this time, he visited our ER for further management of the patient. And then another point to be noted is, in that hospital, he underwent CT thorax, which showed right-sided consolidation with mild minimal pleural effusion, but it was majorly a collapse consolidation with few atelectatic changes, predominantly on the right side, which was pretty much in sync with our clinical findings. So this was the
Are
picture.
there any other respiratory symptoms like cough?
No, sir.
No.
In fact, including the upper respiratory tract infection, like running nose or sinusitis features, he didn't have, and naso-oral examination was normal. No pharyngitis symptoms or no upper respiratory tract involvement was there. So this was our presentation.
What is the reason for collapse in a consolidation?
So basically, if a patient is not being able to respire completely, like let's just say in this patient has a right-sided chest pain. So because of the pain, if patient is not able to expand the lungs, then
What is the reason?
some atelectatic changes.
One thing, I'm just secondary to pain only, he's not able to live.
Atelectatic changes.
It is mainly due to the mucus plug obstruction.
Mucus plug.
Atelectasis means it is collapse. The common cause for collapse in pneumonia cases, it is due to the mucus plug. Okay. That is the main reason. So, if the patient is okay, that there is no pain, you have to advise physiotherapy for the patient, lung physiotherapy. If there is pain, then we have to see how can we relieve the symptoms by bronchoscope or anything. Now the patient is having pain, we cannot do any physiotherapy on the chest wall.
Costochondritis can also cause
Costochondritis produces pain. It can produce pain, but this is a case of pneumonia.
pneumonia. So then this was the symptoms as to why he presented. No allergy history, and he wasn't on any medications, no known comorbidities. So in our examination wise, respiratory symptoms were pretty much inconsistent with our primary survey findings, and other symptoms were within normal limits. No raised JVP, no signs of acute pulmonary edema.
If there is JVP raised, what will you suspect?
Could be acute pulmonary edema, right? Heart involvement.
What will you suspect? Somebody is admitted like this in your ER, like a consolidation on the right side, pleuritic chest pain, JVP is elevated, young boy who is not having any heart disease. What is the first diagnosis? It has to be pulmonary embolism.
Embolism.
There is elevated JVP in a young boy who is not having a heart disease and a large consolidation acutely presenting with pleuritic chest pain, then you have to suspect pulmonary embolism. Okay. So actually, how do you diagnose pulmonary embolism on this one?
Then BTC.
Then it is difficult. You can do VQ mismatch study. BTC is ideal thing in emergency room. VQ mismatch, I'm just telling to make you understand what will be the difference between VQ mismatch of pulmonary embolism and difference of VQ mismatch in pneumonia.
Sir, in pulmonary
Ventilation, perfusion, mismatch. Ventilation will be good in pulmonary embolism. Perfusion will be bad in
pneumonia.
Perfusion.
Fish will be bad in embolism.
Embolism. But ventilation will be good in embolism. Just opposite. Ventilation will be bad in pneumonia. Perfusion will be good in pneumonia. So VQ mismatch will give you the picture. But nowadays we are going for CTPA. That is the best thing.
So no signs of acute pulmonary edema also was noted in this patient. So then moving on to the lab investigation wise, patient had an elevated CRP of 150.38, could denote an underlying inflammation with the total counts of 19,600. But a procal came back to be negative of 0.5, and other lab parameters were pretty.
That rules out bacterial infection. It can be viral infection. It can be something else, some other infection or inflammation. So, will you ask about the history of trauma in this patient? Have you asked the history of trauma?
We didn't ask.
Trauma is very important because lung contusions can present like this. Pain will be there. There will be collapse consolidation picture in the X-rays. Okay. So chest trauma is a very important history to be taken.
So and cardiac enzymes and the other lab parameters were negative. So with this diagnosis, we were thinking more in terms of a post-viral sequelae that could have caused either a secondary infection or a extension of a polyserositis. So in our management,
Secondary infection, why you are thinking now at this time?
So
this point of
dengue
time.
fever can cause a secondary superimposed bacterial infection like Streptococcus pneumonia.
And procalcitonin is negative here, completely normal. It's a slight elevation, then you can suspect. In gram-negative infection, it will be very high.
Recent hospitalization, so could be a hospital-acquired infection.
Even then, procalcitonin, if we are believing in procalcitonin, it has to be slightly elevated. Very rarely, it will be negative in a bacterial infection. Especially like this large pneumonia, it has to be, when it is originating from the lung, it has to be elevated. So here it is not elevated. So it has to be mostly an immune-mediated reaction in the lungs because of the primary viral infection.
Hospital-acquired pneumonia, how long after a hospital admission?
48.
48 hours. Now the fever and other things are happening about more than a week.
24 hours later. Discharge was on 14th. He landed with infection again on 15th. So these were the findings.
It's not the discharge date. Since admission.
Admission.
From admission 48 hours, then he develops pneumonia. Probably it may be healthcare associated. Okay, good.
Yeah, in the time of admission. Okay. So the rest of the parameters were normal, sir. So we empirically started the patient on antibiotics to prevent any secondary infection, and then conservatively managed this patient with nasal prongs, and he was maintaining oxygen. Along with this, respiratory exercises were taught to the patient. And speaking of the steroids, since we had a strong suspicion of it being an immune mediated reaction, because our bacterial sepsis parameters were negative, we gave 1 dose of corticosteroid.
What will be the ideal
dexamethasone.
antibiotic for this type of patients?
A
Ideal
fluoroquinolone.
antibiotic.
Azithromycin.
You are thinking in different ways. You can think. This is a, like sir told, it can be hospital acquired pneumonia. Sometimes procalcitone can go wrong also. If it is a hospital acquired pneumonia, is there in your mind what antibiotic you start? And we discussed, if it is a dengue fever with immune mediated pneumonia, on other hand, what will you start? What antibiotic? I am telling about antibiotic.
It's hospital acquired, then we'll be thinking more in terms of a pseudomonas or an MRSA.
Okay, so what antibiotic you think? Is it a MRSA pneumonia? Will you suspect MRSA pneumonia with this type of conditions? Why? Staphylococcus pneumonia, normally they are bilateral pneumonia. And if you don't treat 2-3 days, you can see cavities inside. Mainly it will be bilateral pneumonia. Normally it is not a consolidation. Whereas other pneumonias like Klebsiella, Pseudomonas, they all come as consolidations, and sometimes it will become necrotizing pneumonias. Cavities can form. Okay, whatever it is, when the patient is coming from a different hospital, consolidation, here it is not bilateral pneumonia, consolidation, what will be your antibiotic of choice? There you have to suspect Klebsiella, Pseudomonas, like that gram-negative organism. What will you start?
Fluoro.
Piperacillin plus Cleander.
Piperacillin tazobactam is a good antibiotic. Okay, that can be given. She is telling quinolones. Can you start quinolones? They are also good. Quinolones will cover Pseudomonas. It will cover Klebsiella.
Penicillin group.
Penicillin?
Group of drugs. Sir.
Penicillin group of drugs, normally they are not, penicillin means amoxicillin,
Amoxicillin,
augmentin, ampicillin, sulbactam, like that. They are not good for hospital acquired pneumonias. Okay. Suppose it is viral pneumonia, and secondary to viral pneumonia, there is an immune mediated pneumonia. I'm not talking about a secondary infection, immune mediated pneumonia. If at all you want to start an antibiotic, which antibiotic do you prefer?
Azithromycin.
Azithromycin is the choice, because that has got an anti-inflammatory action in the respiratory tract. Okay, you are not giving the antibiotic here to prevent the infection or to treat the infection. You are just giving this antibiotic as part of your anti-inflammatory measure in the lungs. That action is there for azithromycin, but it has to be given for longer days. Then only that inflammatory action will come into picture. But if you are giving an antibiotic without any reason, azithromycin will be a safe choice. That's all.
Okay. So then the patient was conservatively managed, and
Steroid was given.
steroid was given. So dexamethasone was given.
Okay.
0.15 mg per kg would be the dose. So then following a dose of steroids and then our conservative management, in a span of 48 hours, he's been so far during his stay of course of stay in the hospital, he hasn't had any further spikes of fever, and symptomatically also he became better. Oxygen supplementation concentration was titrated, and now he's off nasal prongs. In room air, now he maintains saturation of 96-97%. So symptomatically and clinically, he has improved in a span of 48 hours. The idea was, if the patient continues to have these symptoms, and if symptoms persisted, then perhaps we would have had an option of going with bronchoscopy.
Okay. In a patient who is having pleuritic chest pain or rib pain, somebody is having malignancy and they can have rib pain, what are the ways you can improve the breathing? Because that will be the cause for the hypoxemia here, not because of the pneumonia. You have seen a lot of pneumonia in consolidation. They don't develop this much hypoxemia. Why this patient is developing hypoxemia? That is because of the pain. More pain. He is not able to breathe. So how can you help him?
NSAID will reduce
NSAIDs
the
can be
pleuritic
given,
chest
but
pain.
this is a dengue fever. Platelet can be low, and creatinine can be elevated. And you have to see all these things, and you can give NSAID. That is correct.
Then
What?
opioid patches.
Opioid patch will take time, 24 hours. The most important drug will be morphine. So this type of patients, you have to give a small dose of morphine, 2 milligram or 1 milligram subcutaneous. Then you can put the patch. Patch will take time to act. Buprenorphine patch. But we have to give a small dose of morphine or some fentanyl to relieve the pain. If you relieve the pain, the saturation will improve. Even if you give oxygen properly, after sometimes again it will come down because he is having pain. And steroid also will be helpful. Steroid can be given to reduce the inflammation, pleural effusion, all these things.
And then IgE levels were sensor, and that came out to be 488.6.
It's normal. It is not very high. Why did we send IgE levels?
Again, allergy. Yeah.
No, he is running a pet
Parasitic.
shop. That's why we send pet shop. Pet shop means a lot of birds, excreta, all this. It's dandruff. All these things can come. They can have a lot of occupational related lung diseases. So in that IgE levels will be very high. Okay, that's why we send IgE level. If IgE levels are very high, then again steroid is the treatment of choice, or steroid sparing drugs can be given. Okay, but it is normal.
488.
So it may be related to dengue, but it is an immune mediated reaction in the lungs secondary to dengue fever. Normally dengue will not produce lung parenchymal disease in after the second week. First week he can develop.
What was your X-ray finding?
X-ray bilaterally there was whiteout. The lower zones were whiteout, sir. So possibly a collapsed lung. But initially we thought it was
Void and
white.
Oh, white. Okay.
Initially we thought it was probably pleural effusion, so we did a bedside lung ultrasound. It didn't show any effusion. It was just it just had the collapse consolidation part, predominantly lower zones. Upper zones were clear.
Okay.
So in ICU X-ray, that you have to be very careful. ICU X-rays, pleural effusion means it will be like a haziness throughout the lung field. Only when the patient is lying down, if you are taking an X-ray, only lower part is white. It cannot be pleural effusion. What we are telling is on standing. Erect X-ray. That means PA view. This is AP view. When we are lying down, pleural effusion is spread on the posterior surface. They get a uniform haziness. Pleural effusion will look like that in supine X-rays. Standing X-rays, it will be like a pleural effusion.
With the treatment, what was the auscultatory finding?
Sir, crepitations had come down, and because of oxygenation and patient started respiratory exercises and pain got down, then his air entry improved in the lower zones.
Any
Minimal
chest
creps
X-ray
he still
repeated?
has.
Any repeat X-ray did you?
Repeat X-rays just it hasn't had much of a change as such, but it is becoming more organized.
And in case of fever, see, we have to keep in mind about hydration, micturition, all these things.
Yes,
Whether for 1 week he had been there in another hospital, taken food regularly or not. Any episode of altered level of consciousness because of the fever or hypotension, because sometimes aspiration possibilities also may be there. That also keep in mind.
And recent dengue in case of fluid loss. Yeah.
So one more thing. This patient actually had mainly like a sequelae secondary to like an inflammatory issue, like maybe a post dengue or maybe some other antigen or some hypersensitive relation like has caused a pneumonitis like picture. So even after the acute issue, these patients need to be followed up, because actually post this issue the patient can go into like a permanent ILD or like an idiopathic pulmonary fibrosis in the later stage. So immediately after discharge they have to be like treated, like taught how to like continue the respiratory exercise even at home also, and also to start on spirometry and everything to open up the collapsed sepsis, like alveoli should be opened up, and also we have to like monitor the patient for developing any fibrotic changes. And also this glucocorticoids may have to be continued like during sending home also, like you can change it to like oral prednisolone, which can be continued for some more time until the lung the patches resolve. Because if you are like leaving him like then like in a midway, then the skin can go for a permanent change, like fibrotic changes. Also then later then we may have to like start drugs like anti-fibrotic drugs maybe needed to be started to like clear that patch and all that. That's one thing that patient need, like respiratory follow-up for like a longer period of time. So this patient is yet to go into the discharge phase, but he's improving over time from our post-admission.
And physiotherapy?
Lung physio also actually we can initiate
on.
once the pain has subsided.
And sent to spirometry.
So the requirement of pain is actually like the analgesics is coming down over time, so we can slowly start him on physio, like in the coming days like that.
Anything else, sir?
Good.
Okay.
Thank you,
Thank
sir.
you.